3, 2, 1, please begin.
Welcome to the AMDA webinar. Dr. Priya Kishnani and Dr. John Sleesman, an informative session on the COVID-19 vaccine with questions and answers. Your speakers for today's program are Priya S. Kishnani, MD, CL, and Sue Chin, Professor of Pediatrics for the Department of Pediatrics, Division of Medical Genetics at Duke University Medical Center, and Dr. John Sleesman, who is the Dr. Glenn A. Kaiser and Ethel Muriel Kaiser Professor of Pediatrics and Division Chief of the Division of Allergy, Immunology, and Pulmonary Medicine. He holds a joint appointment in the Department of Pediatrics and Pathology and is co-director of the Duke Immunology Laboratory. Now, as a note, the list of credentials for both doctors has been greatly shortened for the preservation of time. Audiocast quality is subject to your equipment, available bandwidth, and internet traffic. If you experience unsatisfactory audio quality, please use the telephone dial-in option provided in your confirmation and reminder emails. If you have dialed in, operator assistance is available by pressing £0. You can send questions at any time by using the Q&A box located on the lower left of the presentation screen. Type your message at the bottom of the Q&A box and press Enter to send it. A question and answer session will follow the presentation. I will now turn the call over to Dr. Kishnani and Dr. Sleesman. Doctors, please begin.
Hello, everyone, and a good afternoon, good morning, good evening. I can see that there are individuals from different parts, and it's really a pleasure and an honor, as always, to be able to provide updates and information. My dear friend and colleague, Dr. Sleesman, is the true expert here in terms of the vaccine, and I know he has a few slides, and then the idea was to open it up to questions and answers before we wrap up. So thank you, and hope everyone is staying safe.
Thanks, Priya. It's a pleasure to be talking to you and adapting to the new virtual world that we live in. I'm sorry I can't see all currently 65 of you out there. And you're fortunate that all you have to see of me is my headshot. But I have to tell you, with the advent of COVID, I'm not seeing the barber as much. My hair is much longer than it is in the photograph. I wanted to walk through a little bit of background about coronavirus and SARS-CoV-2, as I like to call it, tell you about how this vaccine was made, and give you a little bit of the nuance between the two different types of vaccines that are currently approved in the United States, the one made by Pfizer and the other one made by Moderna. And then we noticed that there's a large number of questions, so I'm not going to go through a long presentation, but we will open it up for your questions, and then I'm going to go over on the last slide about some of the precautions that the CDC has recommended. So with no further ado, if we could just have that first slide in that slide set. And by the way, I've made this slide set available to you all. All of the slides, if you want to look at it, was made by the CDC. So let's go to the top slide, which we're on 29 now. So let's go up to 1. So kind of next slide. Next slide. Great. Okay, so this picture here is the enemy. This is the SARS-CoV-2 virus. It is a member of the coronavirus family, and specifically is a member of the beta coronaviruses. Coronaviruses are everywhere. All of us have been infected with coronavirus because it's one of the common causes of upper respiratory tract infections in all of us. But this particular coronavirus, called a beta coronavirus, was a virus that jumped from most likely a bat population, into the human population about 2013. We've known about this virus for some time and have been hoping that it would not become a pandemic, but sure enough, in 2019 and early part of 2020, it jumped into the human population and it's caused this incredible pandemic of upper respiratory tract infection worldwide. The reason that we're so concerned about this virus, it is 5 to 10 times more virulent than the influenza A and causes death in about 1.5% of people that are infected with the virus. So this is a virus that carries a lot of morbidity as well as mortality with it, in spite of the fact that it's for all intents and purposes, a cold virus. Now, you're going to hear a lot of alphabet soup today, but we're going to talk about messenger RNA and RNA viruses. So this is an RNA virus, which means that its genetic material is not the standard DNA, where DNA goes to RNA and then goes to protein. It's RNA. So it hijacks the mechanisms of which proteins are made within an infected cell. And when we talk about the vaccine, we're going to talk about how we use that same hijacking system to make a vaccine. It's very clever and really represents a huge advance in human vaccine development. The way that the vaccine was developed extremely rapidly over a very short period of time through a collaboration with pharmaceutical companies, and specifically we'll talk about Moderna and Pfizer and the National Institutes of Health. I think it's important that third bullet point to understand that this particular virus is an emergency authorization. So when people go to get their vaccine, like I got my second one yesterday, they're going to say that this is an experimental vaccine because it was not fully vetted out and fully tested the way vaccines are usually analyzed, but there were 30,000 individuals enrolled in the preliminary phase 3 trial. So we do have a lot of data, and every day we're getting more and more data about this virus. Next slide. So getting this whole idea of explaining mRNA COVID vaccine is that important take-home messages if this is not a live virus. This is not a protein. This is messenger RNA. So there is no risk to someone who gets the vaccine that you are going to be infected. You may get sick, as we'll talk about in a minute, but you're not going to become infected with SARS-CoV-2 as a result of the vaccine, because only the genetic material of the vaccine is included. The other thing to keep in mind, and I get asked this question a lot, is that there's no DNA. So many of my patients have asked me, well, how do I know that this vaccine isn't going to get integrated into my genome? That's not possible because we're not actually giving DNA, we're giving the RNA. Next slide. So maybe this is kind of the last slide that I'm going to show before we open it up for questions and discussion, and this might help you get a better understanding of what's going on. So our geneticists, like Dr. Kishnani, have for many years, used the idea of electroporation to insert DNA into a cell so that they could insert a gene that they wanted to study. And this has been going on for decades. So the typical way that works is you put DNA into the cell. It gets the DNA becomes activated to make the messenger RNA, and the messenger RNA makes the proteins that get expressed. In this situation, we're taking the RNA vaccine. In this case, it's the RNA of the SARS-CoV-2 virus, put it into an envelope, and that's what gets inserted into your arm or muscles. And that RNA then makes the viral protein, and that enables an infected cell now to carry that message of viral proteins to the immune system and allows you to make both antibody responses as well as cellular responses. This is a tremendous advance in vaccine technology. To date, this is really the first RNA vaccine that has been tested broadly. We have tried to use an RNA vaccine to fight Ebola. There's a number of clinical trials that have been done to try to develop an HIV vaccine for AIDS using this technology, but this is the first time that it's been really used in large-scale vaccine delivery. Now, you're going to hear, you've already heard, and I saw there were several questions about Moderna versus Pfizer. The two vaccines themselves are very, very similar in their construction. There's some nuances between the RNA sequences that are used, but the principles are exactly the same. There's also some differences in the stability of the vaccine in that the Pfizer vaccine has to be maintained at a colder temperature for the vaccine to be stable compared to the Moderna vaccine. But that being said, in terms of the adverse reactions that occur with the vaccines, the immunogenicity, they are extremely similar. There will be other vaccines that are coming down the line that are more traditional and based on just giving the viral proteins, but right now these are the only two vaccines that are being tested in the United States. So I'm going to stop there and open it up to questions or concerns that you might have, and then I have a final slide that I'd like to show once the questions have been answered that will kind of summarize the questions that you have, particularly about who should be getting the vaccine and its safety.
John, thank you so much for. Yes, so John, thank you so much for this. And many of our patients with Pompey have worried over time because of the added potential risks that they could have because of early pulmonary involvement or respiratory involvement. As far as I know, and this is actually even for patients to speak up, the few that I've heard of that contracted COVID with Pompey disease have actually recovered and done well. We've not had any ill effects or deaths as it relates to COVID in the amongst our patients with Pompey. So that has been the really good news and a testament to our patients who have continued to receive the enzyme safely and where family members have taken all the needed precautions to keep their loved ones safe. So I just wanted you to know this, Dr. Sleesman, and if there is anything different, then we would really encourage patients to bring that up as we speak today as well.
Well, Priya, thanks. That is an extremely important point. I mean, we had huge concerns as the pandemic started about how our immunocompromised patients would be affected, how some of our patients, for example, with asthma and underlying pulmonary conditions would be affected. But what we're happy to report is the overall morbidity and mortality among even immunocompromised patients has not been as high as we expected. Now, we're still seeing that sort of 1.5% to 2% of deaths among all populations with clearly advanced age, and particularly age over 65, as well as underlying comorbidities such as underlying chronic obstructive pulmonary disease, diabetes, and cardiovascular disease being a higher risk. The patients that I have with primary immune deficiency that I have lost have fallen into those risk groups, whereas my younger patients with primary immune deficiency, even those patients that have had transplants, have not done any worse than the general population, and that's really good news. That is not to trivialize this virus. It is still a very deadly virus, and I encourage my patients, if they come down with COVID, to let me know. there are some patients who need to be treated actually with immune suppression because they make a very robust response against the immune response against the virus, and that's actually what gets folks into trouble. So we've even used drugs like dexamethasone to decrease some of the pulmonary symptoms that occur when folks become ill.
Thank you, John. Mike, did you want to open this up for questions? And then between Dr. Sleesman and myself, we would try and address them.
I would be honored to, Doctor. The first question we have is there underlying benefit or side effects concern for which vendor, Pfizer or Moderna, that Pompey patients should be aware?
So from my perspective,
From
my perspective, the two vaccines are equivalent. Both of them have, there's been a lot of discussion about one of the excipients that's the additive to the virus called polyethylene glycol. Both of those excipients are in both the Moderna and the Pfizer vaccine. So we don't, so they're equally at risk. But I have to point out that allergic reactions to polyethylene glycol are exceedingly rare. And the reactions that they get are more like anaphylaxis. So it's a reaction that occurs immediately after the administration of the vaccine. In those patients that I've worked with Priya on who are receiving enzyme replacement therapy, most of those reactions are not what we call immediate hypersensitivity. They're more like intolerance of the infusions that occur during or after it, but not the immediate anaphylactic type reactions like someone would get if they are allergic to peanuts and were to eat a peanut. Would you agree with that, Priya?
Yes, completely and fully, because I know this has been a concern for many of our patients. And I would also like to add to this is that the only one suggestion is not to combine receiving the vaccine on the same day as you're receiving your enzyme treatment. I think separating it by a few days would be helpful so that you prevent the development of infusion-associated reactions or the potential for it, where we are not sure what the driver of it is. So that's one thing that I have recommended to our patients is that definitely as it becomes available, and we consider our patients with Pompey to be higher risk patients, so to go forward and receive the vaccine, but just don't do it on the same day as your enzyme treatment.
Okay. Another question for you. Any patients that are participating in gene therapy trials most likely shouldn't take any form of vaccinations while they're on immunosuppressants regimens. Once no longer on immunosuppressants, what is the minimum time frame after stopping taking this type of drug? Would it be safe for immune systems to return to normal and be vaccinated for COVID-19?
Sure. So I could start this and Dr. Sleesman can continue. So the vast majority of patients that have been in gene therapy trials have received steroids in the form of prednisone at 1 milligram per kilogram, and these are then tapering doses over a 4-week period. I don't think that you should do the vaccination at that time. I mean, you could wait and do it afterwards, but the half-life is not that long. So I would say, John, do you think it's reasonable to say like a month after the last dose, they could receive the immunization?
Right. So we're recommending for all of our patients that are on active immune suppression that they not receive the COVID vaccine, primarily because we're afraid it may blunt their immune response. And we just don't have enough data since the trial went through very quickly. There was no patients that were enrolled that were on active immune suppression, so they were excluded. So we have very little data. We will be getting that data as time goes on. So what we tell you today may be different. But in general, we need to wait for the immune suppressive action to to wear off, and that 1 month or at least 1 month before receiving the vaccine is what I would recommend. So if the vaccine is available to you, what I would do is recommend that you defer administration until you're off immunosuppression. Check with your doctor, make sure that we don't need to do any additional immune testing, and then move ahead. We don't have readily available good testing for measuring the vaccine responses. That's something that we're working on feverishly to measure both the cellular immune response by looking at the way that the immune cells respond, as well as the antibody responses following vaccination in immunocompromised patients. And that's a work in progress right now.
Yes, and thank you so much, Dr. Sleesman. In addition to that comment, for those patients who are receiving gene therapy, if there is a spike in the liver enzymes and added immune suppressants are used, or there is the use of agents outside of steroids, then definitely please consult at all levels. Please consult with the treating physician as well as an immunologist to ensure that there is safety for the individual to receive the vaccine.
All righty, Doc. Next question. It comes in as everything I have read about the vaccines for COVID say that if you've had a previous infusion reaction or are allergic to anything in the drug, you need to take caution. I would like some opinions on how to proceed forward. I very much want the vaccine, but a lot of them here in my state are done in a drive-through, and that concerns me given that may not be the proper setting if I had a reaction. I also know that the IVIG reaction I had could have been related to the brand of IVIG along with a lot of other factors.
So amen on the drive-through thing. I think that's crazy. We are recommending, and the CDC is recommending, that everybody be observed for 15 minutes after they've received the vaccine. Now, remember, there's two types of adverse reactions that occur with a vaccine. One is what we call immediate. So these are adverse events that recur within the first 15 to 30 minutes following the administration of the vaccine. They involve a drop in blood pressure, severe abdominal pain, shortness of breath, wheezing, and that needs to be treated with epinephrine. So we are recommending that all individuals who have ever had anaphylaxis or have a history of anaphylaxis bring their epinephrine, their EpiPen, with them when they come for their vaccination. My recommendation to my patients have been to get the vaccine administered in a facility where you can be watched, where they can get vital signs, and the administration of the epinephrine if these immediate hypersensitivity reactions should occur, because they're the ones that are life-threatening. Now, the other type of reactions have been more what we would call idiosyncratic or delayed responses to the vaccines. Those are the fevers, the myalgias, the headaches, the flu-like symptoms. I had those myself after the second dose. Those represent your immune response responding to the genetic material that is in the vaccine, and that's a natural response that we see with many vaccines. It just seems that COVID, the COVID vaccine, can cause a more robust response in folks, say, compared to flu or say a tetanus shot. But the concept is the same. Those are not dangerous. There's been no reported severe reactions with the delayed type, only with the immediate one. So I would say yes. If you have a history of allergies, you have a history of anaphylaxis, you have a history of asthma, you want to be in a scenario that if you do have a reaction, you can be treated easily. And I would encourage you, if you have asthma or if you have this, is you take your medications with you when you get your vaccinations, and so that they're readily on hand.
Dr. Sleesman, that was very informative. And I think many of our patients do have infusion-associated reactions, but just a very small fraction have had hypersensitivity or anaphylaxis or anaphylactoid kind of reactions. So the point really is that should not, neither of them should disqualify you. But,
that's right. That's exactly right. And I'm saying I have many patients on IVIG, and I'm telling them exactly the same thing, that they can proceed with the vaccination.
Correct. And there should be no drive-through for anyone with the COVID vaccine, at least the way we have been, it has been administered for both myself, and I can speak also for Dr. Sleesman, is we are asked to sit outside for about 15 minutes so that if we were to experience anything, we could be taken care of appropriately. And for someone with a history of anaphylaxis, I think bringing that information up front, and I'm sure a longer observation period may be recommended.
Right. We're actually going to be administering the vaccine for people at high risk in our Asthma, Allergy, and Airway Center, where we have nursing personnel that are used to dealing with anaphylactic reactions on hand.
All righty. I have another question for you both. The question reads, I am a carrier of Pompey and would like to know about the COVID shot, if it is dangerous to have the shot. Also, I have lupus, fibromyalgia, and other autoimmune diseases.
Priya, do you want to take that one? And now I can follow up.
Sure, yes. So for someone who's a carrier of Pompey disease, that should not, you may not fall in the category of high risk if you were only a carrier of Pompey disease. And so your timing of receiving the vaccine may be more dependent on your age and, the risk stratification by which you would receive the vaccine. Now, in addition, if I heard the question correctly, there is also a history of autoimmune disease in this individual. Is that correct, Michael?
I'm sorry, please repeat.
Yes, there was a history of fibromyalgia and lupus.
Correct. So, John, if you wanted to address, and if you could address that aspect of it, because I don't.
Yeah, this is a very good question, and I, with full disclosure, I'm boarded as a rheumatologist as well. This is a big concern because folks with lupus are always, and fibromyalgia are always concerned that vaccines make them more symptomatic. In the case of the fibromyalgia and chronic fatigue syndrome, we have seen transient increases in symptoms following vaccinations. The difficulty is in terms of assessing the risk benefits is that if you get wild type COVID or if you get wild type influenza, your reactions are much worse. So you're paying the price of a short-term increase in symptoms to avoid the serious consequences that may occur if you get wild type disease. So it's an individual choice, but I have to say that there are some patients who have fibromyalgia who have had pretty severe post-vaccine headaches, low-grade fever, joint pain that we've had to treat with increasing their non-steroidal anti-inflammatory agents to cope with that. But it's been all transient.
Okay. Next question. Are there any recommendations to pre-medicate prior to getting the vaccine as a precaution?
No specific recommendations, but lots of people are doing it. I've been asked that question. I mean, there's no good data yet. I'm sure that there will be. Someone will collect the data and compare patients who took, you say, 400 milligrams of ibuprofen before the vaccine versus ones that didn't. But right now, we don't have any data, but certainly isn't going to help. And I do that for my patients with IVIG. I said, make sure you're well hydrated before you get your gamma globulin. Take 400 milligrams of ibuprofen. And in some cases, I've even had to give low-dose prednisone for those post-infusion headaches. I have not had anyone request has had post-infusion headaches after the COVID vaccine that has had to go on to prednisone, but we've been able to treat it just with the non-steroidal ibuprofen or naproxen.
Okay. Doctors, would you advise children under 16 with infantile Pompey to receive the vaccine?
I don't think we could qualify anyone under 16. There are clinical trials underway, and once we have data, then for sure, if there's safety that's shown and efficacy, which my guess is it would be, then yes, children under 16 could receive the vaccine. For right now, it's just not available. It's only approved for those 16 and older.
All righty. Next question. If someone has already had COVID-19, why would they still need to be vaccinated? For example, if a child gets chickenpox, then they don't typically get a chickenpox vaccine.
That's a good question. We don't know the nature of immunity to wild-type virus. The reason that recommendation is there is that there's been numerous reports in the medical literature of individuals that had wild-type naturally infection with COVID that have been reinfected, and that went into the decision that even if individuals have had wild-type virus, they should still receive the vaccine. The only caveat I would add to that is in those individuals who have had natural COVID infection, when they got their first dose of vaccine, they tended to have more in the way of side effects in terms of headache and low-grade fever. That has not been published. This is just an observation that came out on the MMWR and from other information from the CDC.
Okay.
The one piece of information, maybe if I could add, and Dr. Sleesman could add to this as well. I wanted to reassure our parents, who have children with Pompey. Children overall have done well with COVID, and we actually had a very interesting and very informative grand rounds by our group here at Duke, which actually showed that even going to school, these children did quite well because the mitigation strategies or the strategies to keep them safe were very good. And for those children who did contract COVID, this is not in the school setting, this is just irrespective. They mount a very good antibody response or an immune response to the COVID, to the virus. So until we have more data on children who are under 16 years of age to receive the vaccine, I want our pediatric, our families of pediatric patients to continue the good work that you have done with, good hand washing, mask wearing, continuing with the enzyme infusion safely. And overall, the data we have up to now is that they have done extremely well.
Okay. Would receiving one of the COVID vaccines cause an issue with potentially being able to receive gene therapy in the future?
I can try and take this one, and this has actually been floating around a lot. The idea was, I think there's a misunderstanding or terminology. So the AstraZeneca vaccine, which is not available in the USA, this is the one that is being developed by Oxford in the United Kingdom, is an adenovirus-based vaccine, but that is not adeno-associated virus, which is the common vector which is being used for gene therapy trials. And there is no cross-reactivity between adenovirus and adeno-associated virus. So even for those theoretically who have received the AstraZeneca vaccine, that would not disqualify them for a gene therapy trial of AAV. John, would you like to add anything more to this?
No, I think you nailed it on it. That's a question that I've heard for, the sort of confusion about the different constructs that are being used for the vaccine development. Perfect, thank you.
Would one vaccine be better than the other concerning gene therapy? I mean, the Moderna and the Pfizer vaccine? Is there either one that would be better if somebody is contemplating gene therapy?
Not at all. I think they are equivalent because the technology platforms are similar. These are mRNA based, and so would not interfere with receiving gene therapy at all.
Okay. Now, we've talked about children getting the vaccine, and I've asked about a child with infantile. What about if it's late onset? I understand the child and the age, that's not tested for children 16 and under. But what about late onset children? Is the vaccine safe?
It's the same principle for anyone who's under 16 years of age. The vaccine is currently not available for to be given. And so once the testing is done and there's more data available, then I would say that the children with infantile as well as with late onset should receive the vaccine. Of course, it's a personal choice, but if there should be no concerns once there's data available for those who are 16 and under.
Thank you. As a virus mutates, how will this affect the vaccine that you've already taken?
No, let me read the question.
I
think I got it. John, you could answer it. As the virus mutates, will this decrease the efficacy of the current vaccine? How well does the Pfizer vaccine work against the UK strain versus the Moderna one?
Yeah, that's a good question, and it actually links into one of the other questions I saw someone ask about why didn't RNA vaccines work in the HIV clinical trials. So if you think about RNA viruses and DNA viruses like chickenpox and mononucleosis, for example, are the most stable in terms of their genome. They don't mutate away from the immune system as quickly as RNA viruses. And among the RNA viruses, the lentiviruses like HIV have the highest rate of mutation. And that's one of the reasons why the RNA vaccines in the HIV setting have not been effective. The virus has just found a way around the vaccine. The good news is, and I hate to sound political, but the good news is that at least for this particular coronavirus so far, we have been extremely lucky that the mutations that have occurred have increased its ability to spread, but it has not either affected the overall morbidity or mortality, nor has it decreased the effectiveness of the vaccine. So in other words, the mutations that have occurred have not occurred in parts of the virus that would allow it to escape the immune system. So right now, the immune system is winning. The longer we have this virus out of control worldwide, the more likely it is it will escape. And so it's extremely important that we do two things. One is that by using masks and social distancing, washing our hands, not gathering in large groups, that we curtail the spread of the virus, because each time the virus is passed from one person to another, each time the virus replicates, you create a possibility it's going to mutate. And then obviously the solution is to have a vaccine that will slow down the spread, slow down transmission, and the more the virus, the less virus there is, the less chance it has to mutate. So we're in a race against time right now to get this vaccine out, to get it to decrease the spread. And then in that case, if we can get the case numbers down worldwide, then there's a very good chance this vaccine may have efficacy for many, many years. Alternatively, if the virus continues to replicate out of control, pass on to more and more individuals, then a mutation that would affect the efficacy of the virus is likely, and we'll be right back to square one.
All righty, doctors. Now, I know that we have covered a lot of things, and there's going to be some questions that sound a lot like previous questions. And I will ask those because there's a good possibility that somebody signed into the webinar a little bit late and was not able to hear the answer. So if some of the questions sounds like we're repeating ourselves, that's the reason. I want to ask you, would it be best to receive the COVID-19 vaccine now as a Pompey patient?
Yes, I would say yes, as long as there are no specific reasons which would exclude individuals with Pompey to get the vaccine. I would definitely, I have recommended it to my patients to receive it at the earliest, as long as there are no contraindications for it. So there was another question here on the chat, which was, is it safe to get the vaccine while pregnant? And John, you could help me answer this, but I believe those data are being evaluated now, so it's currently not approved, right? For
right, we'll go over this on the last slide. It's under what's called caution.
Sure. I'm just trying to go through the questions to see if there's anything else. Michael, you can too. Oh, and how long does it take?
Go ahead, Doc.
Yeah, how long does it take until one is immune after the vaccination? So Dr. Sleetsman, maybe you can state the importance of the 2 doses and how much after the first versus the second is the conversion.
Well, the good news is, and this is one of the reasons why this vaccine was licensed and approved by the FDA so quickly, is that the initial assessment of the viral efficacy, and that is just to explain to people how the trial was done. So both of the trials were randomized to you either got a placebo, a shot that had no vaccine in it, or you got the vaccine. And then those individuals, since the United States has one, if not the highest prevalence of SARS-CoV-2 in its population, those folks went off on their day-to-day activities, and we just counted the number, followed the people closely, the number of people who became infected versus the number of individuals who did not become infected. And after 30 days, there was clearly efficacy of the virus, of the vaccine in preventing viral infections, 90% efficacy, and that's really blew me away. Influenza is only, depending on the year and the vaccine, somewhere between 40 and 60% effective in protecting you from infection. This was 90% effective. So that's really incredible news, incredibly good news. Now, the bad news is we don't know how long folks are going to be protected against the virus. How long will that immunity last? How long will they make antibodies? How long will they make T-cell responses? And then, of course, there's a question of the virus mutating that may make the immunity that you have not effective against new genetic variants of the vaccine. But as we get more of that data from the clinical trial, as these patients or these volunteers are being followed more closely, we'll give you a better answer for that. Remember that we're less.
Okay.
These trials started less than a year ago, so we don't even have a year's worth of data on the people that participated in the trial, let alone people that have gotten the vaccines since it's been authorized.
Once you get the vaccine, can you still contract COVID, or are you immune to it?
90%. That's the best I can tell. So the risk is not zero, and that's why we still recommend that you mask. We still recommend that you social distance, but there is the protection does appear to be 90% in terms of contracting the infection.
The other aspect also, John, maybe we can add that as well, is the vaccine would also hopefully make the infection with COVID less severe. So someone who's
yes, that's a very good point, Priya. Yeah.
And so that's the other safety or advantage of taking the vaccine.
So what you're saying is 90% will be immune, and those who actually get COVID will get a lighter case of COVID?
That's what's speculated. Yes. Yes.
Would you recommend the vaccines with the old technology like the Chinese Sinopharm for people with late onset Pompe?
I don't know that would have any. I'm not a Pompey's expert. I don't know why that would have any particular advantage or disadvantage for folks with Pompey's. Maybe Priya, you can comment on that.
I'm sorry, I just lost connectivity for a moment. What was the question about patients? Like, would they benefit from?
Would you recommend that vaccines with old school technology like the Chinese Sinopharm for people with onset Pompe?
I don't think that our patients with late onset should be receiving vaccines with a different platform than the current one. Dr. Sleesman, do you have any additional thoughts on this?
I don't know of any data that would suggest that protein platform has any advantage over the RNA platform. With the caveat is that one of the reasons that the RNA platform rolled out first was because we can make more doses faster. Now, I know that some of the reports, this is not a Pompey's issue, this is the report of the vaccine efficacy, that some of the reports from the countries that have used the Chinese platform have shown that the efficacy is not as great as the mRNA, but none of that has been published, so that is still to be vetted out and peer reviewed before we can make any real comparisons between vaccine products.
Okay. I have a question for you, but I would like a shot at answering it, if you don't mind, first, and just to see if I'm right. Following the second dose of whichever vaccine is available, what precautions need to be taken? Are they okay to stop shielding following the second dose? My guess would be if you have 90% efficacy, there's still going to be a portion of people that get the COVID-19 And even though they may have fewer symptoms or even be asymptomatic, they could still be contagious. So out of the love for our fellow human beings, we would still want to shield, wear our masks, wash our hands, and maintain social distancing. Doctors, am I anywhere close on that?
Amen. I really want to be able to go to a restaurant. I really want to be able to visit my granddaughter. I really want to fly on an airplane again before I die. So the sooner we get this under control with masks, hand washing, not congregating in large groups, and everybody getting vaccinated, the sooner I'll be able to go down on a plane.
Okay.
Agreed.
Yay. Thank you, Doctor. Go ahead, Dr. Kishnani.
No, I fully agree with Dr. Sleesman. We still have to follow the precautions as recommended by the CDC, even after one is vaccinated. And I'm sure Dr. Sleesman would like to share some of those or that particular slide to bring that point and that message home.
Yeah, if we could just pull up that slide 29 on my slide set, I think we could probably end with what the current recommendations are. And remember, guys, when I say it's 29 on the slide set, yeah, that's perfect. What we tell you today may not necessarily be what we tell you tomorrow. So don't come back and say, well, the doctor told me in January that it was okay, and then we changed our mind. Yeah, we are getting more and more information all the time in terms of this. But I wanted to break this down into conditions, and particularly about this issues of allergies, which is kind of on the vertical axis, and then the proceed with vaccination, precaution to vaccination, and then contraindications to receiving the vaccine. So getting to that question of pregnancy and lactation, it's a caution because we don't have enough data in pregnant women and lactating women to really say that this is fully safe, but it's an individual choice. You know, when you compare your risk for acquiring infection. For example, many of our physicians who are lactating, but they work in the emergency department or in clinics where they see COVID patients, are opting to get the vaccine. Patients with allergies, and these are particularly to the common allergies, people who are allergic to cats, people who are allergic to bee stings, or even latex, or a history of a medication hypersensitivity. Those risks are very low, and they can get away with just the 15-minute observation period that occurs with everyone who receives the vaccine. The ones that where we would do precautions and maybe even consider deferring the vaccination would be if you have an acute illness, like an acute cold or acute exacerbation of an illness. That might be a reason to defer. In people who have had severe allergies or a history of any of reactions to any of the components to the vaccine. In this group, the polyethylene glycol would be the thing that would be on our highest risk radar. Those individuals need to be observed for a 30-minute period for observations. The only one that's an absolute contraindication at this time are the people who are known to have a severe allergic reaction to the first vaccine. They should not receive the second vaccine. So that kind of summarizes at least where we are as of right now. This recommendation are both for the Pfizer and the Moderna vaccines. It's just when this slide deck was made by the CDC, the Pfizer vaccine was the only one that was approved, so that's why it says Pfizer on it. Anything else?
Yes, yes. What about close family history of mast cell activation syndrome combined with an effusion reaction?
That would fall into my precautions to vaccination with a 30-minute observation period.
Okay. If you're a carrier of Pompey, are you more at risk than someone who's not?
That's a question for Priya. I don't have any. I don't have any. Know of any data that those individuals have been at higher risk. Maybe Priya might know.
This is for who? Caregivers?
Carriers. Do carriers have a higher risk of anaphylaxis?
No.
Okay.
No, not at all. Not at all.
Okay.
There are so many carriers, in the general population that we're not even aware of. So we do not expect that at all.
Okay. I know that Tiffany had a few questions, but has been unable to get through. Luke, our operator, could you unmute Tiffany?
Just give me a moment.
All righty.
Go ahead, Tiffany.
Hi.
Your line is open.
Hi, can y'all hear me?
Hi, Tiffany. Yes, I
Yes.
hear you.
Hi, Priya. Yeah, I think most of them have already been answered. I think, really something as a take home, maybe a final question would be what type of precautions, and it's just sort of asked in terms of the shielding. After the vaccine, those of us with very, compromised pulmonary functions, etc., is it safe for us to begin resuming our lives if we mask, etc., or do we need to continue, shielding at home until there is more of a herd immunity?
I'll take a first crack and then I'll allow Dr. Koopman as the immunologist to also speak on this. I do believe that if individuals have been immunized or have been vaccinated and they can get into the workforce, but of course with precautions of hand washing, appropriate masking, and wherever possible is still limiting ourselves to smaller numbers. But I would not say that we have to be completely shielded at all. We all have to look at the pros and the cons here, and I think here the pros are more in being able to be functional members of society, as all of you have been. And if you receive the vaccine, and if your work does require you to go in, I think it's reasonable to go in. But of course, following precautions even post-vaccination. Dr. Koopman, would you agree?
Yes, this is a tough question. That is not unique to this group or anybody else. Everybody is dying to get back to their daily lives, to be able to get back to school, get back to work, not to have to wear these silly masks. But I just have to point out that the last week has been the deadliest in the United States since the pandemic. We're losing people to COVID rates, of over 3,000 per day. The current trajectory will be over 1 million before we get this under control. So I really think it's a multi-pronged attack. The multi-pronged attack is for us to, now that we know that masks are effective in preventing transmission from an infected individual to an uninfected individual, now that we know that social distancing is effective, and hopefully the vaccine will make a major dent in the pandemic. The problem has been the rollout of the vaccine. We are still way behind where we projected to be. We were hoping to have 20 million vaccinations done before the new year, and we're only at about 7 million right now. And our healthcare delivery systems are overwhelmed in trying to take care of all the patients as well as administer the vaccine at the same time. At Duke and at other places, we're looking for volunteers basically to do 24/7 to administer the vaccines to people who can get them if we can get enough vaccines. So I think that there is some light at the end of the tunnel as the vaccine does roll out. I will breathe a sigh of relief when I start to see that curve on the Hopkins website start to come down. But right now it's still going up, up, up. So I think we have to do all of those things for the time being. So I still, even though I've been vaccinated, I still have my mask.
Yep. And likewise. And so that's the message, that having received a vaccine does not make us so immune privileged, so to say, that, we can go out without wearing masks and precautions, and wherever possible, it can be done remotely. Follow that, to the best that you can.
And doctors, I have a question. There have been lots of reports, mostly on social media, that the pandemic is a hoax. And then also that the vaccines will make hair grow out of places hair is not supposed to grow out of. Cover you in wild rashes and boils. But would you please address those reports?
Well, I was hoping that you were telling the truth about the hair. If you guys see my picture, you'll understand why. I can tell you that this virus is not a hoax. This virus is as bad as any virus I have. This is my second pandemic. The first pandemic was the HIV pandemic in the 80s and 90s, where I lost many, many patients to AIDS. And I have lost patients to SARS-CoV-2. I recently had a 31-year-old woman who I've taken care of her whole life pass away in Daytona Beach, Florida. And she died alone, and her mother couldn't be with her or anybody else because she was infectious. So to say that this is a hoax really does our country a disservice. We have to take this virus seriously. We can control it, much like we have controlled the HIV pandemic in the United States. We don't have a good antiviral yet. There's some promise that some of the monoclonal antibodies might be helpful in treating people who get SARS infection, but we still don't have a magic bullet that once you get infected, we can cure you. So right now, the vaccine and social distancing, preventive measures is all we really have in our armamentarium. But this is a major issue that's affected everyone, not just in the U.S., but obviously worldwide. It's just that for reasons that I don't really understand, the United States has not done a very good job of taking this pandemic seriously and really curtailing it like other countries have done.
And the vaccines don't have mild side effects? I'm sorry, Dr. Kishnani, I couldn't.
I wish that hair thing was true. I'm going to go Google that and find out. Priya, did you have a comment?
No, I was going to say I've heard of many of the side effects, but this was not one that I was aware of.
Maybe if I rubbed it on the top of my head, I could get some hair growth.
Yes, first get it to be able to rub it on top of your head, right? But Michael, we are past the hour. I do have a next meeting in the next few minutes. So I just wanted to be sure that all questions have been addressed for our patients.
I think that there was one more, if y'all can still hear me. The question was, does sulfasalazine count as an immunosuppressant? This is from a patient who was diagnosed at 5 months, but is now 27. And he just wanted to know, he does take that, so where does it put him risk-wise? And does it affect his ability to get the vaccine?
Well, I'll take that one, Priya. All I can say is that mild immunosuppressants, and I would include drugs like Plaquenil, sulfasalazine, nonsteroidal agents, are weak immunosuppressants, and at least in other vaccines, they have not really attenuated the immune response to the point that the vaccines were not effective. What I'm telling my patients now is if you're on a short-term immunosuppressant, say an asthmatic that's on 5 days of prednisone, or someone who is being treated for some other inflammatory condition, if you can defer the vaccine until you're off, that would obviously be the safest. But patients who are on sulfasalazine, Plaquenil, et cetera, usually are on that because they have some underlying autoimmune or, say, inflammatory bowel disease type things. I would recommend that you go ahead and receive that vaccine.
Thank you.
All right. I would really like to thank everyone who participated from my standpoint, but Tiffany, I know you did too, so I'm going to step aside and just tell everybody thank you.
Yes, thank you, Michael, and thank you to both of you for giving us your time and answering the questions of our community. I think we all understand that COVID-19 has brought a lot of uncertainty and a lot of questions about what is the right thing to do and when. And I believe that today was a fantastic step forward in answering those as it relates to the vaccine. So thank you both so very, very much. And thank you everybody who participated and asked your questions. I hope you got them answered. If you have a question that was not answered, please email it to the AMDA and we will work at getting it answered for you.
Thank you so much.
Thank you again, everybody.
Yeah, and the AMDA, I also wanted to thank Dr. Sleesman. I know he rearranged his calendar to be available for this time for today. So thank you so much, John. And all of you, just on behalf of us here, stay safe, and we hope to meet you all in person soon when things allow it. Thank you.
It was a pleasure to be with you guys. Hopefully we can give you an update in a few months that will answer some of the unanswered questions that everybody had. This is, like I said, a work in progress, and what we tell you today may not necessarily be what we tell you 2 months from now. So stay tuned.
Yay. You just committed yourself, Doctor. I'm going to hold you to it.
All right, I gave a talk to the Immune Deficiency Foundation in February of 2020, and many of the things I told them, say, for example, about masks and things, turned out not to be correct. So I've had to talk to them on more than one occasion as well. But you guys aren't the only one asking hard questions.
Hey. Well, from all of us here at the AMDA, we appreciate your time. This will conclude today's webinar. Again, thank you.
The moderator has ended the conference. Goodbye. Thank you for calling.